Hi everyone, I'm back again. Thanks for watching. I want to talk about end of life care. Well, it's a topic that many of us will find very difficult, including myself, but whether we like it or not, we are all going there. It's a question of time. Okay, let's go. It's going to be a teamwork. So, from the beginning, you have to involve everyone religious leaders, depending on the choice of the affected patient, cultural people and practices that the individual believes in, the palliative care team of the establishment or the jurisdiction where you're working, social workers within the hospital or the jurisdiction where you are, involve family members' place because we are not butchers and we can't just do anything without involving the family members. Particularly at this point is very critical. Why? We have to explain every steps and medications we are given with possible anticipated side effects to the family members. And we're going to allow family members to say goodbye to their loved ones. It's going to be painful, but we have to be empathic and we must show concern for the dying person. Okay, with that, let's go. The end of life care is such that is the care given in the last days or hours of life. It includes relieving physical problems, emotional and spiritual concerns. Social issues should be addressed as well. We have to plan ahead of time, particularly if all factors are pointing to end of life. For example, if this individual has been battling with a terminal illness, or this is a cancer patient already on palliative or supportive treatment only. In other words, this is a cancer patient with no hope of cure. This is not a case of Hodgkin lymphoma with 80% possibility of complete remission. Still talking about end of life care, modern hospice movement is about comfort. It's not about cure. Like I said when I started, we're all going to get to this point, including myself. So we need to pause and be careful. The individual passing through it today will not be the last person. Unfortunately, it is inevitable. The goal is to let the affected person die peacefully, make family members happy, and you, as a physician in charge, will have a clear conscience that what? That you've done all. So hold nothing good back. More people will choose to die at home. Another goal is don't prolong the death for no reason. You understand? What are we going to be faced with? At this stage, we're going to see some symptoms like pain, dyspnea, restlessness, agitation, delirium, nausea, vomiting, jerking, twitching, renal incontinence, noisy breathing, and the individual may be non-verbal. What are the possible investigations that we're going to do here? We're just going to take adequate history, have physical examination. Please don't bother about elaborate investigations at this point. After all, the affected person is going. No radiological investigations, because of what use? Before you finish your radiological investigations and you embark on any intervention, the affected individual might even gone. But why not allowing him or her to go peacefully? Or if at all you just have to do it, then at the lowest rate. What are the possible treatments here? We are going to go back to the record of this patient. Any advance directive before now. With that, we're going to know the values of this individual, the wishes, the goals, and the treatment will go along that direction. Advance directive. Maybe this person has said no resuscitation. Not this, not that. We're going to follow that. Okay? If we are unable to get that, then we're going to get substitute decision maker. And of course, the power of attorney, if available. We're going to discuss with family or substitute decision maker or anyone with the power of attorney. We'll discuss the possibility of organ donation with the family, depending on the age and the cause of death of the affected individual. When it comes to dyspnea, we'll start by reassuring the family members, and if the dying person could still have some few energies, maybe we'll just encourage breathing exercise or relaxation technique. Can use electric fan, open the windows, supply oxygen by mask at the rate that is comfortable to the affected individual. It would be wise to elevate the head of the bed. You can give morphine here, 5 to 10 milligram intravenously or subcutaneously, every 30 minutes or every 4 hours, with 1 hour breakthrough doses. Fentanyl sublingual at 25 to 50 microgram is welcome. And of course, hydromorphone. Still on dyspnea, can use clonazepam, diazepam, razepam, or midazolam. If you're not winning, you can go for phenotazines like chlorpromazine or promethazine. Promethazine is both antiemetics and chlorpromazine is also antiemetics. Razepam could also be used as antiemetics. You may use steroids if there's dyspnea, if you know the history that the dyspnea here is secondary to chronic obstructive pulmonary disease, or this is secondary to asthmatic attack or cystic fibrosis, or you're dealing with lymphangitic carcinomatosis. If you are handling a dying patient and you are confronted with pain, kindly check my video on nociceptive and neuropathic pain here. I'm not saying there and then, no, but before you get to that situation, it's better you equip yourself thoroughly with the pieces of info that I've supplied there. I will not go through them here so that I won't waste your time. We start handling pains, any type it is, using World Health Organization ladder approach to pain treatment, and that will involve starting from non-opioids. The history of the pain and specific helpful analgesics in the past will be necessary. In other words, you ask the patient, have you had this pain in the past? So, because that is someone who could talk, right? But if the dying patient is non-verbal, then you ask the substitution maker, who must have been very familiar with the heads of the affected person. So, what have you used to suppress this pain in the past? And if you're able to get that, why wasting your time? Just prescribe the same. If this is a mind pain, you can use acetaminophen, that is paracetamol or Tylenol, depending on where you are on the surface of the earth, or aspirin. You can use non-steroidal anti-inflammatory drugs or combination of two of these three. If it's a moderate pain, you can use opioid by use low dose, or you use those ones with low potency, and you may add adjuvants on top of that. If it's a severe pain, you use high potent opioids like morphine, hydromorphone, and fentanyl. And on top of that, you can add adjuvants. Note this, avoid meperidine because of its neurotoxic metabolite. You can use corticosteroid if it is bone pain or hepatic capsular pain. An example here is dexamethasone 4 to 8 mg per oral, or subcutaneously or intravenously. If you're administering opioids, or this person has been taking opioids before, then get prepared to handle the side effects. And I'll go over some of them briefly as nausea. If you're dealing with nausea as side effects of opioid, grab your Gravol or metoclopramide. If you're dealing with constipation, polyethylene glycol, Bisacol-D, or Xenocort S, that is with cyanide, will be helpful. If you're battling with somnolency, just reassure. And pruritus, go for your antihistamines like Benadryl, Loratadine, steroid cream, or you change the medication. If you are dealing with dry mouth, then get eye chips or chew gums. If the problem is neurotoxicity with myoclonus, please change the medication. Or if the problem is neurotoxicity with delirium, please change the medication. If you are dealing with neurotoxicity with visual hallucinations, change the medication. And with that, I've come to the end of the first part of the treatment of end of life. I will go to the next presentation, that will be end of life chapter 2. So immediately I'm done now. The next publication will follow a couple of hours, let's say in the next 1-2 hours. So thanks for listening. Kindly subscribe to my channel. Check the end of life treatment 2 hours after you receive this. If you subscribe to my channel, you'll be getting my presentation immediately they're published. Thank you.